Dear students, in this video, I'm going to discuss about the interpretation of galactomannan and beta-D glucan to guide antifungal therapy in the ICU. These are two important tests which we need to confirm before we continue antifungal therapy if we have started or if we haven't started to guide us to start the therapy. So it is important to know what these tests are actually meant to detect. The galactomannan, it detects a polysaccharide antigen which is released by the aspergillus cell walls, primarily aspergillus fumigatus. It is best validated in hematologic malignancies, in hematopoietic stem cell transplants, prolonged neutropenia, and of course, to some extent, in other immunocompromised patients in the ICU. Typically, it is reported as Galactomannan index, with serum cutoffs being around 0.5 to 1, they are used, while BAL cutoffs are usually higher, more than 1. The beta-D glucan or 1,3 beta-D glucan, which is another antifungal test, detects pan-fungal cell wall component, which is present in Candida, Aspergillus, Pneumocystis, or others, and not in organisms like Mucorales or Cryptococcus. And this is reported in picograms per ml, common cutoff being around 80 picograms per ml, especially in India and in South Asia. But the performance varies by population, so the cutoff has to be validated as per the population. It has high sensitivity for invasive fungal infections, but lower specificity, and hence false positives in many ICU situations are also common. If you look into this study, which was published in 2009, the third European Conference on Infections in Leukemia Group in Critical Care, they found that whenever these studies are combined, the performance of combined testing is superior to either of them being tested alone. And the same was also seen in 2005 in the Journal of Clinical Microbiology, that particularly in the diagnosis of invasive aspergillosis in high-risk hematological patients, they were considered useful, but the combination was useful specifically to identify false positive reactions by each test. Although so much has changed after that, and on many occasions, even combined tests may not give that benefit which it was presumed to be given at that point of time. But this study, which was published from in India much later, has also seen the sensitivity and the specificity and has evaluated the cutoffs, which was quite similar to one which was seen in the West. But overall, the beta-D glucan has good sensitivity and specificity for distinguishing invasive fungal infections from no invasive fungal infections. And galactomannan index is considered to be useful for diagnosing specifically or particularly for invasive aspergillosis. So let us start with some cases. A case 1, neutropenic 55-year-old with AML on induction chemotherapy, now in the ICU with persistent fever, pleuritic chest pain, hemoptysis with new nodular lung infiltrates and also halo sign on CT chest. The risk factors are obviously prolonged neutropenia, steroids, broad spectrum antibiotics. And obviously, the question in the mind of clinician is, do we have enough to call probable invasive pulmonary aspergillosis and start targeted therapy, or how do the galactomannan and the beta-D glucan can help? Now, we have to order the right samples. The serum galactomannan and beta-D glucan, if not on mold active prophylaxis, yet should be sent. The BAL galactomannan and the BAL culture microscopy and, if possible, aspergillus PCR, if bronchoscopy is possible and safe. You have to interpret the galactomannan in case of serum galactomannan more than 0.5 to 1 in this host with compatible CT findings and host factors will strongly support probable invasive pulmonary aspergillosis. BAL galactomannan index of more than 1 has high sensitivity and specificity for invasive pulmonary aspergillosis in high-risk patients like this. And when we look for interpreting this together with galactomannan, beta D glucan is often positive in IPA, but it is less specific. A high BDG plus positive galactomannan increases the post-test probability of invasive fungal infections. If galactomannan is positive and BDG is positive in an appropriate host with CT findings, most studies will support starting or continuing your anti-mold therapy as probable disease. But when the results are discordant, when the galactomannan is positive and the beta D glucan is negative, we still think of aspergillus because galactomannan is more specific. We repeat the beta D glucan, review the timing, and look for alternative causes if they are clinically seen to be atypical. If beta D glucan is positive, galactomannan is negative, we consider other fungi like Candida, pneumocystis, etc. And of course, we have to consider the ICU false positives and or even correlate with the site of infection. So in neutropenic ICU patients with typical CT findings and host factors, a positive BAL galactomannan virtually clinches the probable invasive pulmonary aspergillosis. Serum galactomannan and BDG support, but they do not replace radiology and mycology. Coming on to case 2, 70-year-old COPD patient mechanically ventilated for ARDS on steroids and broad-spectrum antibiotics. CT shows new nodular infiltrates, but he is non-neutropenic. Sputum shows Aspergillus fumigatus, and the scenario which it typically exemplifies is common in mixed medical ICUs, where Aspergillus can be both colonizer or it can be a pathogen. So how to use galactomannan and beta-D glucan here? We have to recognize the limitations in non-neutropenic ICU patients where the galactomannan sensitivity and specificity are lower in non-neutropenic patients than in hematologic malignancy or hematopoietic stem cell transplant. Beta-D glucan has frequent false positives from bacterial infections, hemodialysis if the patient is on, albumin or IVIG, and in some antibiotics too. So we should have a reasonable strategy to obtain BAL galactomannan instead of relying on serum galactomannan. BAL galactomannan is more informative in this particular group. And add beta-D glucan as a supportive marker. Interpret cautiously, although keeping in mind that a single positive beta-D glucan is not enough to call invasive fungal infections. So we have to go for a case-based interpretation, that is BAL galactomannan more than one with compatible CT findings and host factors like steroids, chronic lung disease, etc. We have to consider probable invasive pulmonary aspergillosis and start therapy. If BAL galactomannan is negative, serum galactomannan is negative, BDG is mildly positive, sputum culture is positive only, then colonization is more likely, and we continue careful surveillance and look for alternative causes of ARDS. So in non-neutropenic ventilated ICU patients, aspergillus in sputum plus a weakly positive BDG without compatible imaging or BAL galactomannan is more likely a colonization rather than invasive pulmonary aspergillosis. Let us come to case 3, a 62-year-old post-operative patient after bowel perforation surgery who is now in ICU with septic shock, persistent fever, multiple positive blood cultures for Candida glabrata, although the transthoracic echo is inconclusive. So what is the role of beta-D glucan? Beta-D glucan is useful as a supportive tool for invasive candidiasis, including deep-seated infection and candidemia. So high or persistently positive beta-D glucan during treatment may suggest ongoing deep focus like endocarditis, hepatosplenic disease, etc., or even inadequate source control. A negative beta-D glucan in the right time window can help argue against disseminated infection, but not enough to stop therapy alone. So use beta-D glucan to support the diagnosis and monitor trend in invasive candidiasis in the ICU, but never let beta-D glucan override clear blood culture or other clinical evidence. Let us come to case 4, HIV patient with low CD4 or solid organ transplant patient on high-dose steroids in ICU with progressive hypoxemia, diffuse bilateral ground glass opacity. So differentials would be pneumocystis jirovecii, viral pneumonia, diffuse alveolar hemorrhage, ARDS or other causes. Now, what is the role of these two biomarkers? So here also, beta-D glucan is often markedly elevated in pneumocystis jirovecii and can support diagnosis when combined with imaging and bronchoscopy or oblique PCR when it is available. Galactomannan is less central here, and of course, and beta-D glucan is the more useful marker. So in an at-risk ICU patient with diffuse ground glass opacities, very high BDG plus compatible bronchoscopic findings strongly supports pneumocystis jirovecii, but confirmed with organism-specific testing like PCR or DFA whenever is possible. So there are certain common pitfalls and false positives in the ICU, which can be BDG, beta-D glucan false positives in hemodialysis with cellulose membranes, exposure to certain IV products like albumin, IVIG, gauge exposure, severe bacterial sepsis, antibiotics like piperacillin, tazobactam, or amoxicillin clavulinate in some series. Then mucosal damage with massive bacterial translocation can also raise beta-D glucan without true invasive fungal infections. The galactomannan can be false positive with certain beta-lactam antibiotics. Again, historically, peptides, some enteral feeds and colonizations can cause low-level positivity. Inappropriate cutoff values or testing during mold active antifungal prophylaxis may also lower the sensitivity. Timing issues may be problematic because single isolated positive results, especially if it is borderline in ICU, should usually be repeated and interpreted with a wider context. So what we can do follow a simple bedside algorithm. In the first step, identify the host and the risk factors. If it is hematologic malignancy or hematopoietic stem cell transplant or neutropenia, then galactomannan and beta-D glucan can be powerful for invasive pulmonary aspergillosis. For non-neutropenic ventilated patients, galactomannan is more useful. Beta-D glucan is only supportive. Both are less specific. In intra-abdominal sepsis or candidemia, beta-D glucan for invasive candidiasis is good. Galactomannan is not useful. In the risk of pneumocystis jirovecii, beta-D glucan is supportive, but organism-specific testing needs to be added. Next step is to choose the specimen correctly, that is serum galactomannan and BDG for screening in high-risk hematologic or transplant patients, and galactomannan for suspected IPA in ICU with pulmonary lesions. Then step 3, combine the biomarkers, imaging and microbiology. Use investigations or ICU adapted criteria with host factors, imaging and mycology, and plug the GM and BDG findings into the mycological evidence domain. Proven, probable, possible IFI categories can be seen from how strongly we can commit to the antifungal therapy. We have to be beware of the false positives. We review the dialysis, antibiotic exposure, blood products, colonization, and antifungal prophylaxis when interpreting galactomannan or beta-D glucan. And of course, we should follow dynamics rather than single values. Rising or persistently high galactomannan or beta-D glucan during therapy may reflect ongoing infection or inadequate source control. Falling levels may support treatment response, although this is far from perfect. Thank you.